Hello, I'm Dr. Jane Houston, and I would like to introduce Dr. Nicole Lassiter, a certified nurse midwife and assistant professor in the Department of Midwifery and Women's Health at Frontier Nursing University, also known as FNU. Today, we are honoured to present to you a TeamSTEPPS-based communication quality improvement project for effective and efficient transfer from birth centre to hospital. Dr. Lassiter's 2019 Doctorate in Nursing Practice project involved Boulder, Colorado's local freestanding birth centre and hospital. Nicole is passionate about the inextricable connections amongst prenatal health, safety and communication, and we look forward to sharing the story, the data gathered, interpretations and lessons learned from this quality improvement project.
And this is Dr. Jane Houston. She's an associate professor and certified nurse midwife and the director of the DNP program at FNU. She was my mentor during my DNP coursework. Originally from Scotland, she has worked in birth center settings in the state of Florida for over 6 years. She's very interested in equity issues around birth and identifies it as a sexual and gender minority person. Additional research interests include water birth, international maternal quality care, and delayed cord clamping.
The Quality Improvement Project took place at the Birth Centre of Boulder, a freestanding accredited birth centre in Boulder, Colorado, located 2.5 miles or less than 7 minutes from the local hospital, Boulder Community Hospital or BCH. After roughly 5 months of clinical preparation and planning, Dr. Lassiter implemented 4 Plan, Do, Study, Act PDSA cycles based on the Institute for Healthcare Improvement's quality improvement model used by hundreds of healthcare organizations around the world.
First, let's talk about why I was inspired by this topic. Essentially, why communication is so important in the healthcare setting. Maternal morbidity and mortality in the US have increased significantly in the last decade. Communication failures are a root cause of adverse maternal and perinatal outcomes and sentinel events. Handoff communication during interfacility patient transfer is especially prone to medical error. And studies on litigation show that up to 30% of all malpractice claims involve poor communication at their root.
In addition, poor teamwork increases adverse outcomes and poor patient experience. Better communication among providers, patients, and facilities leads to improved quality of care and outcomes. A systematic approach featuring standardized teamwork communication is essential for patient safety and quality care, especially for transfers from birth centres to hospital. A successful transfer that maintains effective communication, delivers timely, specific healthcare information, and preserves patient safety is a complicated process. Therefore, written and face-to-face verbal communication should be based on standardized tools.
Since this project took place at the local birth center in Boulder, let's zoom out for a moment and take a look at this model of care on a national level. The freestanding birth center model of care is growing rapidly in the US and is a viable and innovative solution to the need for safer and higher quality maternity care. While the majority of women receiving care at a birth center will deliver on site, studies show that up to 11.6 or between 11.6 and 37.4% of women will require an interfacility transfer at some point in their care from the birth center to hospital.
At the beginning of this project, the Birth Centre of Boulder, BCOB, lacked standardized communication processes for interfacility transfers, necessitating process changes for improvement. Transfer documentation was not consistently complete. A standardized debriefing process and documentation of this process did not exist. And while regular discussion regarding potential transfer from birth centre to hospital took place at every prenatal visit. There was no standardised patient education or shared decision-making process.
Those involved in the project were the providers and staff at the birth center, including the nurse midwives, RNs, chief financial officer, manager, and receptionist. The providers and staff at the local hospital included the nurse midwives, RNs, obstetricians, director of nursing, and the chief medical officer of Boulder Community Hospital, and the patient population at the birth center or hospital when birth center patients were transferred.
The aim of the project was reached. Over a 90-day period, the transfer tool for complete patient information and the debriefing processes for improved communication were implemented. Improvements in effective and efficient communication and documentation were reached 76% of the time, surpassing the project goal. Improvement in team engagement and patient education were accomplished.
So, what exactly did we do? Our team implemented 4 tests of change that focused on team building at the birth center, a transfer tool to provide complete information to the hospital staff when a patient was transferred from the birth center, a prenatal shared decision-making tool to prepare patients in case of a transfer, and a debriefing tool for every event, whether it was a birth, a transfer, or a simulation.
In the PDSA cycle, P stands for plan to test the change. D is carrying out the test or do. S stands for study and learning from the change, and A is for act, decide how to improve or alter the change for best results. While we review the 4 tests of change, we will focus on debriefing as a quality improvement measure for written and verbal communication between the birth center of Boulder and the local hospital, BCH.
Here are some of the main resources used for this project. The debriefing tool and process was based mainly on TeamSTEPPS, an evidence-based teamwork system designed for healthcare professionals to improve communication, patient safety, and teamwork skills. Developed by the Department of Defense's Patient Safety Program in collaboration with the Agency for Healthcare Research and Quality, TeamSTEPPS is scientifically rooted in more than 20 years of research.
The next 3 slides demonstrate the debriefing tool created for every labour, transfer and birth. At the top we listed the who as anyone present at the event, the what as an informational exchange to last ideally less than 5 minutes to review the team's performance, the when after every birth or transfer, the where, ideally in a private, confidential space, and the why, because of the following listed evidence-based benefits of good communication. These are: improves team performance, effectiveness, and job satisfaction, improves safety of patient care, provides opportunity for lessons learned, reinforces positive behaviours, and helps resolve misunderstandings and unspoken tensions.
Then in the middle of the page on the debrief tool, as you can see here, are the actual questions for the team to address to debrief after every event. So for the healthcare providers, 1, success, what went well? 2, improvement, what should improve? And what do you wish went differently? 3, communication, was it clear, accurate, professional, considerate? 4, roles and responsibilities. Was it understood? Were those roles understood? Were they clear or unclear? 5, workload. Was it equitable? 6, task assistance. Was it requested or offered? 7, resources. Were they available? And if not, what's needed? 8, shared decision-making. Was there shared decision-making with the patient? And if not, what needs improvement? 9, patient-centered care. Did this occur? And if not, what needs improvement? 10, errors. Were there any made? Were they avoided? Or were there any near misses? And 11, anything else? that needed to be discussed.
And finally, at the bottom of the page, the questions to debrief with the patient. 1. How was your experience? 2. What do you wish went differently? And 3. Anything your care providers could have done better?
Over the 8-week period, qualitative and quantitative data was gathered, data was plotted on run charts, and analyzed for needed changes which were made throughout every PDSA cycle.
The highlights of the project included over 100 people participated, including patients, providers, and staff. With 100% attendance, the BCOB team members exhibited high team performance, collaboration, and overall willingness to engage in systems change despite short staffing and reported fatigue. An improved transfer tool was designed and staff evaluated the tool as valuable and useful. Both birth centre and hospital providers collaborated in the design and approval of the tool. And last but not least, at 88%, the standardised debriefing process was a resounding success with implementation and high inter-facility engagement from both the birth centre and the hospital.
Here's a table of the results for all 4 interventions and tests of change. However, we'll focus on the last entry at the bottom, the debrief tool. In each 2-week cycle, our goal of performing the debrief process, whether at the birth center or at the local hospital, was met continuously after the first cycle for a total of 28 debriefs.
Let's take a look at the run chart of the debrief process. As you can see, the debrief tool was used about almost 100% of the time, except for a few times due to lack of time or, in the beginning, a lack of familiarity with the tool. Simulations were performed at staff meetings in order to better orient the providers to the tool.
This run chart indicates that providers from both the birth center and hospital rated the debriefing tool and process as effective and valuable. The lower scores indicate required changes. These changes were then made and implemented. By the last PDSA cycle, per provider request, this debrief form, as you can see here, was changed to a laminated guide as opposed to charting integrated into the patient record.
This run chart indicates that halfway through the project, providers were able to complete the debrief process and the tool in less than 5 minutes.
At the end of the project, the data revealed that interventions at the birth center led to improved transfer-related communication and documentation, team building, and patient engagement.
Fast forward 1 year to summer 2020. The birth centre recently contacted Dr. Lassiter to discuss updating their debrief process. The medical director and midwife explained there had been significant practice reorganisation and staff turnover since the project the year before. After further discussion with the CNM staff, it was made clear that while they regularly debriefed with each other and the patient after events, it was often with 2 simple questions, as opposed to the more time-consuming 11 TeamSTEPPS questions used during the DNP project. These were, what went well, and what would we like to be different?
Thus, the cycle of quality improvement continues according to the needs of the providers and patients who remain at the center of this process. And here are our references. Thank you for joining us.